Hi everyone, this is Karen O'Hara, Director of Marketing and Communications with WorkCare. Welcome to our 25th consecutive week of preventing and managing COVID-19 in the workplace. Thank you for joining us again. You've been a regular attendee, and to anyone who's new, we're glad you could join us. For the duration of the webinar, you will be on mute. Please ask your questions at any point using the Q&A function on the Zoom application. At the conclusion of Dr. Harris's remarks, we'll take questions for about 10 minutes. We answer as many questions as we can in the time we've allowed. We try to keep it to a total of 40 minutes in the interest of protecting everyone's time. So we always summarize all the questions, including those that don't get answered live, in a written version that we put on our website on a weekly basis. So if you check on the WorkCare website, you'll see 24 weeks worth now, and by the end of the week, there'll be number 25. So it's a great resource. We also record the session, and we post that on our YouTube channel, which Alexis will post the link to during the session. Let me introduce Dr. Harris, who's our speaker every week. Anthony Harris, MD, MBA, MPH, is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and our Associate Medical Director for on-site clinical operations. He's also the lead clinician for our COVID-19 response. So I'll turn it over to him. Thanks again for joining us.
Excellent, excellent. Thank you, Karen. And thanks everyone for joining us once again. We are pleased to continue to bring this information to you on a weekly basis. We're going to have some fun today. We're going to talk about CDC recommendations and trying to understand the CDC recommendations a little bit better because as you all may have heard, they've gotten convoluted and confusing for everyone. So we're going to jump right into it. The style of the presentation today will be familiar to most here who have joined us again. We'll talk about the clinical update, some pathology, microbiology. We'll do the numbers with our epidemiology, go into our prevention, and then finally our strategy for how WorkCare can help impact your preventative strategies at your workplace. With that being said, again, I always want to remind Karen to jump in if you hear my voice going in and out, and we'll try to fix any IT issues here quickly. So let's get into it. When we talk about the CDC recommendations, we want to focus in on asymptomatic individuals, okay? And this cartoon here comes from a site that talks about, well, you know, what does it mean to be asymptomatic with COVID-19, right? I feel fine, right? And as we all know, we've been talking about the asymptomatic population for quite some time and trying to control exposures for those individuals who have COVID and are asymptomatic has been a definitive strategy for us since this all really began, and we realized and recognized kind of in May time frame that asymptomatics were a primary spreader or transmission source for COVID-19. So no new symptoms that we're going to talk about today. We're going to focus in on the lack of symptoms and the impact from the exposure to these individuals potentially. So let's jump to the new CDC guidance. And what are they saying? What have they said? Last week on the 20th, the CDC met, the government has this task force, which I know you're familiar with. And the task force met on the 20th, and the following week, last week, they came out with new recommendations. And those new recommendations focused in on these asymptomatic individuals and contact with someone who may have or confirmed to have COVID-19. And so the CDC said, if you've been in close contact, 6 feet with someone with COVID-19 for at least 15 minutes, but you do not have symptoms, you do not necessarily need to be tested unless you are in this vulnerable population of your or your healthcare provider or state or local healthcare officials recommend you take a COVID-19 test. Okay, and this statement in and of itself, distilled down, means that our strategy that we've deployed in the past, where if you were exposed to an individual with COVID-19, we wanted to get you tested appropriately as soon as possible where testing was available, so we could notify anyone you've been in contact with subsequently and do contact tracing, right? And this has been kind of tried and true for quite some time now in terms of strategy. The guidance continues in a different section of CDC, right? That if an individual, if you realize that you, well, it's important to realize that you can be infected and spread the virus, but feel well and have no symptoms, right? And this is not new on the CDC, but it's important to hold this in context in light of the new guidance. And CDC further says, such in areas where there's a limited number of cases, state and local public health officials may request tests on a small number of asymptomatic healthy people, particularly in vulnerable populations. Furthermore, if there's significant spread of the virus in your community, state and local public health officials may request testing on asymptomatic healthy people, particularly from the vulnerable population, right? So in short, what CDC is also saying in this guidance here, that's currently the recommendation, is that although they recommend not testing if you've been exposed and are asymptomatic, they still recognize the state and local health officials may deploy a testing strategy to help understand and prevent transmission when appropriate, right? So right away, we're seeing conflicting recommendations coming out of CDC. And so what we want to do today is get to the heart of the science and the support and kind of what we should do. We don't want to leave you all, our valued customers, our valued clients and employers in limbo, wondering what's the best next step forward with regard to protecting your workforce in light of these new recommendations that seem to be at odds with what we have known to be best practices in the past. So I'm gonna make sure that we're all on the same page with regard to understanding two critical definitions. The definition between, and I'm gonna jump out of PowerPoint mode and we're gonna play this video here because we wanna know the definition between what quarantine is and what isolation is, right? So quarantine is if you've been potentially exposed to someone with COVID-19, you head home, right? That's the classic example that we know when someone flags and says, I've been in contact, we want you to go home and quarantine, and currently it's 14 days. Isolation, on the other hand, is if you've been in contact and you have symptoms or you tested positive for COVID-19, you need to isolate. And that's the 10-day recommendation that we've talked about. 10 days after a positive test, 10 days after onset of symptoms, you're to isolate for that period of time, and you should no longer be infectious after that period has expired, okay? So I wanna make sure we're all on the same page in that regard. Jumping back into the PowerPoint here, we wanna now talk about additional current quarantine recommendations from CDC. So who needs to quarantine? People who have been exposed or in close contact with someone with COVID-19, except excluding people who have had COVID-19 for the past 3 months. Okay, so we got to break that down, right? CDC is saying in these statements that if you've contracted COVID-19, we recognize that you may be positive, and this is confirmed, right? That you may be positive for up to 3 months, right? And you may develop symptoms again within that 3-month period. And they recognize that those individuals who have recovered from COVID-19 in that 3-month period may not need to quarantine after a secondary exposure, okay? Now, this also is in light of the case that we presented to you last week or the week before where now we know and we have the first documented case of a reinfection in Hong Kong. CDC unfortunately has not updated their guidance or has not updated their recommendations around that. Indeed, they're currently saying that there are no confirmed cases of reinfection. So they got some work to do there. But we want to make sure that we understand still their guidance on who needs to be quarantined. And it's clear close contact is the factor with someone who is COVID-19 positive, and the physical contact thereof is germane to that exposure, okay? So now let's look at a breakdown from CDC on several case scenarios, right? And they've updated this case scenario as recent as end of July of this year. And it talks about 4 different scenarios, and then scenario number 5 being the current state as we know it with the information around COVID-19 that we've been able to gather so far, okay? And each scenario looks at several factors that play out from an epidemiology standpoint, and it looks at the R naught in that top row, right? R naught mean, and we'll break down what and remind everybody what R naught is. We've talked about it before, but that essentially is how infectious is the virus itself. Talks about the importance of the fatality ratio, goes through infectiousness of asymptomatic people, infectiousness of asymptomatic relative to symptomatic people, and then, the second infectiousness is percent of infectious asymptomatics, then infectiousness of asymptomatics compared to symptomatics, and then finally percentage of transmission occurring prior to onset of symptoms. Okay, and so scenario 1 is a lower R naught 2.0, whereas scenario 2 has a higher percentage of transmission prior to onset. Worst case scenario of infectiousness, percent of infectious asymptomatic people, and then we jump to the most likely scenario, what we know to be the current state and proportions for each of these factors. Okay. So we want to look at R naught. Let's break that down. Let's remind everyone what R naught means, because R naught is important for understanding the prevalence as well as transmissibility of COVID-19 in general. We want to quickly look at a study that we presented. This was a study done back in May of this year, May 27th. And we want to remind everybody that this study showed us through modeling the effect of transmission rate in the workplace based upon frequency of testing, okay? And we presented this and looked at if you tested once a week, that Monday, on that third line there, the colors here represent, in the blue, no infection. And as we shift up to the yellow and a little bit of the orange, higher rates of infection transmission of COVID-19 in the workplace is modeled out, okay? And so we see quickly that the best way to prevent infection and transmission in the workplace is to have a high frequency of testing. And that's a Monday through Friday testing regimen. Now, again, we're not proposing that everyone go out and test every day, right? We only know of one company that's been able to pull that off, and that was early on in the summer. However, we know that and have seen multiple models showing that the more you test, the more we can prevent infection transmission, not just in the workplace, but in the community as well, okay? And so if we look at what R naught tells us, R naught tells us, frankly, what is the number of people affected by an infected individual, okay? Again, the number of people or contacts that may be infected by one person with COVID-19, okay? And there's a direct correlation there in terms of overall infectiousness of a pandemic or a particular illness, okay? The two factors being time and distance. And that's why we talked about when we presented this a couple months ago, why social distancing is effective, because we can decrease the R naught, okay, the factors in R naught. And if we look specifically at what we understand the R naught of COVID-19 to be, it's 2.5, right? If we look at SARS-CoV-1 back in 2003, it was estimated to be 3.5. If we look at the flu, 1.5. Measles all the way up on the chart there at 16.0. So this means 2.5 people on average are infected by an individual with COVID-19, okay? And so now let's go back to CDC recommendations here, or their scenarios here, right? And again, highlighting and looking at their R naught, and let's highlight a couple of these factors. Let's look at percentage of infectious people that are asymptomatic, and the worst case scenario is 70%. What we think it actually is around 40 to 50%, right? 40% in this depiction here. If we look at infectiousness compared of asymptomatics compared to symptomatic people, worst case scenario, they're 100% infectious, right? Same as symptomatic people. We know it's in actuality a little bit less, right? If you're symptomatic, you're more likely to be infectious than someone who's asymptomatic. 75% is that ratio, okay? And then finally, if we look at percentage transmission occurring from asymptomatic or prior to onset of symptoms, worst case scenario, 70% of the time, someone transmits COVID prior to onset of symptoms. In actuality, we think it's 50%, okay? And this is important to hold in your mind, right? Because again, our strategy with testing is to capture these individuals that have this profile of transmission with the testing regimen accordingly. And if we look specifically at the worst case scenario, R naught of 4.0, right? Flash that forward now to what we presented, or flash backwards rather, to what we presented several months ago on the research calculating and estimating R naught in different areas here in the US. Data out of Wuhan, China, showing an R naught of 2.7, all the way up to an R naught of 5.7, okay? If we look at other data that we presented here, a US study looked at multiple states, calculated relative R naught. If we look at specifically New York State, for example, the R naught was 6.4 that they calculated, okay? So again, if we look back to the estimates here of worst case scenario, R naught of 4.0, and we have estimates of R naught of 6 and above in certain areas of the country. And this was still yet months ago before we had an inflection point again of recrudescence of illness. We are in a most likely worst case scenario at this point in time, okay? So now let's do the numbers. Looking at the epidemiology from 2 weeks ago, 5.4 million cases, 170,000 deaths. We climbed to 5.7 and over 175,000 deaths. Now let's look at a little different graphic here this week. We want to kind of summarize it all and succinctly in a chart here. So total number of cases as of September 7th is over 6 million cases here in the US. 184,000 deaths from COVID so far. And in the last 7 days, the last week, we were almost at that 300,000 new cases in 1 week's time, okay? And we can see the states that are the heaviest hit at this point in time today. We looked at this graphic over a number of months now in terms of deaths by jurisdiction 2 weeks ago, where we were last week. And we also looked at this graphic, new cases on a daily basis, and then looked at it in terms of a trend here, trending down, still growing the total number, but trending downward here. We're going to look at a new perspective on these cases to try to get a sense of the demographics here in the US. So let's break it down by race and ethnicity, right? If we look at cases by race and ethnicity, Hispanics are at 30%, Blacks, non-Hispanics at 19%, whites at 40.6%. So we do see what we all have heard and what we talked about before, about a month and a half ago with Black Lives Matter lecture that we gave. There's still a disproportionality of effect on Blacks and Hispanics, right? If we look at then deaths, we see the same trend. 16% Hispanic, 22% Black. Again, Blacks make up 11% of the US population. That gives us the disproportionality here that we're looking at. And 50%, almost 51% whites in terms of deaths in the US, who makes up that, that number of deaths we just looked at. And then if we look at then and break down demographics according to age, who's getting sick in terms of cases, we see now that 18 to 29-year-olds in the US make up the majority, not the overall majority, but the majority of the age groups, right? The highest in that particular age group. And we see then those 50 to 60 being second. Deaths by age, we don't see a trend change from what we presented at the beginning of this pandemic. Those aged 60 and over and 65 definitely as another inflection point experience greater mortality from COVID-19 infection than do other ages, particularly those who are 40 and under. So now on the global scale, how are we doing? We were seeing, again, a trending downward of daily new cases confirmed over a 6-day rolling average. That was 2 weeks ago. Last week, we saw that trend continue. This week, we're seeing that little arrow there kind of flatten out, right? And so we'll continue to watch that. Obviously, states are still reopening, some universities shutting back down in a major way statewide. So we got to continue to watch this number as we look at then the confirmed deaths on a 7-day rolling average. We saw this flatten 2 weeks ago, kind of decrease a little bit last week. And then this week we see, and I wanted to show our comparison to India and Brazil. We're continuing to trend downward a little bit. And India and Brazil are hanging right there with us. Mexico is on the rise, unfortunately. And so we'll continue to follow this in particular as we now look at testing. Again, these metrics are going to become ever more important as we have the conflicting recommendations from CDC about testing. The US 2 weeks ago, we were still trending downward, which is the right direction for articulating the burden of disease according to this metric, which is share of positive tests. Again, we want lower positive test proportions as we continue to hopefully increase our number of testing in the US. Last week, we continued that trend downward. And this week, we started to flatten, right? And go up a little bit, right? And so again, this change in trend is a little concerning, all right? That some of the recommendations that have come out against testing are now having an impact on our ability to perform in a way that we see other countries who have done fared better comparatively. If we look at then number of daily new tests performed, we stopped looking at this metric a number of weeks ago, but we want to start again, right? So let's see where we're at in terms of overall trend over the months here. We were trending up, and recently, as of last week, again, started to dramatically trend downward. So again, we want to watch this, and hopefully we don't continue to trend downward with total number of tests conducted over a 7-day rolling average, but we'll pay attention to it. If we isolate that number and drill down onto the actual number of tests performed, we were getting ready to, hopefully crush 900,000 tests over a 7-day rolling average in the US alone. And again, we started to dramatically trend down and dropped by almost 100,000 at this point on a daily testing. So when we talk about what's going on in the recommendations of CDC versus the White House administration, you've heard I'm sure reports of pressure from the White House and recommending changes and this and that. Well, frankly, we don't care, right? We in this lecture do not report on politics. We'll leave that to the politicians and to the news outlets. What we do care about, though, is the impact of good science and good epidemiology and good preventative strategies, right? And so we won't be paying attention to the politics of it. Rather, we're going to look at what are the scientists, what are the physicians saying about these recommendations. If we look at Susan Bailey, who heads up the American Medical Association, the president of the Board of Trustees, she says months into the pandemic, we know COVID-19 is spread by asymptomatic people, suggesting that people without symptoms who have known exposure to COVID-19 individuals do not need testing is a recipe for community spread and more spikes in coronavirus. when the Centers for Disease Control and Prevention updates a guidance, the agency should provide a rationale for the change. We urge CDC and the Department of Health and Human Services to release the scientific justification for this change in testing guidelines. Now, I didn't put it in the lecture, but if you guys I want to remind you, we presented changes that were made about a month ago with CDC in terms of the recommendation from 14 days after a positive test or after onset of symptoms to be in self-isolation to 10 days, right? And with that recommendation that CDC made, we also gave the scientific evidence to support it, right? Because CDC also listed and cited those research documents to support those changes. That didn't happen this time, right? And so again, we want to look to what scientific evidence do we have to support recommendations so that we are propagating best practices for our folks that need to do the job we need done to help protect workers. If we look at other prominent physician leadership in the US, Dr. Eric Topol has written a letter in regards to his take on the recommendation and his displeasure with the FDA in particular on supporting these recommendations, right? Dr. Topol is one of the top 10 most cited researchers in the US in terms of heading up Medscape as well. So what are states doing, right? So we heard about what leadership and physician leadership are doing. What are the states doing? Recognize that the states have been given from the White House guidance way back when, kind of the autonomy, right, and the responsibility to create and craft their own testing recommendations for their populations, right? And so if we look at what's being reported now, most states are rejecting the guidance from CDC. If we look at a breakdown of that, we're talking 33 states now have come out against these recommendations, okay? And again, this information is not being propagated by media outlets. This is directly from the health department, right? So we're not talking about a kind of colloquial rejection or a political one. We're talking about flat out the state with their autonomy on creating their own testing strategy is going to continue on the path of, if you're asymptomatic and you have been exposed, you need to be tested if available. So let's dig into that briefly here. And this is the guidance that we want to reassure you at WorkCare we're standing by, right? Because we recognize that, and this is what we've reported on before, we can't take at face value just CDC or WHO or any other, organizing body around preventative strategy. We need to make sure we're looking at all the sources we have available and distilling that down to the best practice as we recommend it to you. So what are we recommending? We're continuing to recommend that if you have someone that is affected because of exposure with COVID-19, you to conduct an interview, right? You're to identify their contacts and that contact tracing. We want to make sure that we're helping you in that, and we have resources if you do need help and assistance with contact tracing. Once we have assigned different contacts to this particular individual, we want to notify them and we want to get them tested, right? If we have it available, and at this point we have nationwide coverage for testing, we can test, and we're still recommending to do so that we can get to the most important next step, which is isolation, right? And knowing when to bring someone back in that 10-day timeline, and not having them out for longer than they need to be necessarily in a 14-day quarantine because we don't know their status. Or if we don't have testing available immediately in that algorithm, then we'll follow up with them on a daily basis from a clinical aspect, and we'll see when it's appropriate and hopefully get them tested so that they can appropriately complete a self-isolation, or they're going to complete their self-quarantine if we still don't have testing available for whatever reason. But again, testing is going to be still a key component to dealing with and preventing asymptomatic individuals in the workplace and the potential for them to transmit to other workers, okay? And if we look at then our overall strategy in regards to investigating each case, we have to keep in mind that it's critical to do the contact tracing. That's what helps reduce the potential for an exponential increase in that contact, right? If we recall that R naught, right, 2.5 people will be contacted and have a transmission of COVID if we don't do and know the individuals that are positive for COVID, right? So doing this piece, having the testing when available, executed on consistently is going to be a key factor in how we get through this pandemic. If you recall, and I'll leave you with this, right? We presented this a number of months, I think about 2 months ago now at this point, but we recommended a testing strategy that is appropriate for the burden of illness, right, for your community or in your community, right? And when we talked about this, and this does align with what CDC I showed you earlier in that chart, where their recommendations of state and local health officials would recommend testing if the burden of disease was substantial, right? And so when we broke that down into real numbers here, we recommended that, hey, look, if you have a burden of illness, 200 out of 100,000 cases, you can have a testing strategy where it's a it's in a return to work scenario, right? And that may be okay to still help prevent transmission in the workplace. If the number rose to 500 out of 100,000, then doing some post-symptomatic testing is appropriate. Post-exposure testing is appropriate to help prevent transmission. And certainly if you're over 1,000, consider, particularly when you're bringing individuals back to the workforce, a testing strategy that is more primary, meaning you have a routine testing strategy. And so I'll leave you with updating you on where we're at with regard to, in the US, the impact and the burden of illness. If you look at the hardest hit states down here in the South, Louisiana, Florida, if you look at Arizona, we're at now 3,200 cases in Louisiana per 100,000. Almost 3,000 in Florida, Arizona 2,800, right? And so we are dramatically over where we started this, obviously, back in earlier summer, and we saw spikes climbing. We're far above that, right? And so that is why it is important to still have a testing strategy as a component of your prevention of transmission in the workplace. So with that, I will stop and we will open it up to questions. Thank you.
Okay, that's really interesting because, you know, it leaves a lot of the burden of states to make these decisions without consistent guidance from the federal government. So it makes it hard if you have a multiple site workplace that crosses into multiple states. It makes it harder for employers to know exactly what to do to be consistent. So thanks for that presentation. It's really helpful.
You bet. And the CDC does recognize that employers have the autonomy to recommend testing strategies and have their employees be compliant between states. And they mentioned that directly in some of their recommendations. Okay,
that's good to know. A couple questions. The first one is actually a situation I experienced just this week where I had a family member who had sinusitis and tested for COVID, and then they were wondering if, while waiting for the test results, the family should quarantine.
Sure, so that's a scenario.
It was just sinusitis, it could be allergy, it could be a cold, whatever you end up having. What do you recommend while you're waiting for a result to come in?
Sure. So the CDC does recommend that if you do eventually get tested because of suspicion, or it's recommended, right, by a healthcare clinician, that you are to self-isolate until you get the results. And that is best practice, right? If you have a high enough concern to get tested, not just in a routine testing scenario, that there's a reason why you want to get tested, such as symptoms, then self-isolation until you have the results is reasonable. However, if you are an essential critical worker, that may not be the scenario, right? You may need to still take necessary precautions. You can still work until you get those results back. And we do have a protocol for that as well, and best practice. In addition, individually, case by case, your physician needs to be involved to help make the call of, yes, we are concerned about coronavirus in this case, or no, this is low likelihood, and with a negative test, the individuals can be potentially returned back or not have to do quarantine, because with low clinical suspicion and a negative test, that does make the risk for coronavirus and transmission much, much lower.
Okay, thank you for answering my question. Now I'm going to jump into our attendees' questions. Any thoughts on the New York Times article on PCR testing being too sensitive and the effect on false positives?
Sure. So I haven't dug into this article in particular. However, in regards to the sensitivity and being too sensitive of a test, does that become problematic, right? And it's not necessarily the sensitivity that is concerning, and as much as if there's high specificity along with sensitivity, then we're reassured that whatever we're detecting, right, at a high rate of detection or high fidelity of detection is in fact what we're looking for. In this case, obviously SARS-CoV-2. So having a high sensitivity and isolation is not a good scenario, right? That does increase your risk of having false positives. But if you have both high sensitivity and high specificity, then you have a good test. And you can be assured that anything that has been detected is what you are concerned about and looking for.
Okay, thank you. Next question. Should an employer require that employees who sit more than 6 feet away from each other also require them to wear a mask at the same time? The CDC says a mask is not a substitute for social distancing. If people are at 6 feet from each other while working, can't they have their mask off unless they get up and walk around or someone comes into their work area? Isn't social distancing the first line of defense?
So while social distancing is a first line of defense, if we look at the hierarchy of controls in terms of industrial hygiene, right, reducing the exposure is always higher ranked in terms of effectiveness than PPE, personal protective equipment, such as a face covering, right? So yes, social distancing is more important. When we talk about the scenario in this case of should we require PPE in addition to social distancing, the answer is yes. And here's why. Because even in a social distance scenario, 6 feet greater, if someone does not practice good cough hygiene, meaning when they cough or they sneeze, they cough into their elbow, the elbow or their hand or something better than just coughing forward with no obstruction to kind of catch those droplets, right? Then their expectorant will and may travel far greater than that 6 foot radius, right? And we know this to be true in multiple studies. So wearing the masks help decrease human error or poor compliance with good cough hygiene, good cough etiquette. And the masks when having a conversation with someone is obviously beneficial, but it even is more beneficial when someone coughs or sneezes.
Okay, we have time for a couple more questions. We're actually at our stopping point, but do you have time to take a couple more, Dr. Harris?
I do. Let's do it.
Okay. Is one daily cleaning for a site that generally sees about 15 employees passing through, but not usually on site all at one time, sufficient for preventing spread of the virus through fomites?
Good question. It is dependent on the nature of the environment itself, right? So is it a common area where people are spending, several hours, but it's only a few people? Or is it a scenario in which people are spending time and they have a number of instruments around them that can become fomites? If it's just a room with a table and, maybe a computer, then you have less chance of surfaces becoming contaminated and, less risk overall from that fomite standpoint. But if it's, a complex environment, you have a lot of surfaces, a lot of difficult to clean surfaces, you may want to consider, in terms of the frequency of that utilization there, having a regimen that is more frequent than just once a day. Once a day can happen and it can be effective, but if it's a continual use, you want to try to have a more regimented scheduling of cleaning.
Okay, this is about contact tracing. Should the contact wait to be tested on day 4 to 5 after exposure and not get tested before that time?
Correct. After being exposed to a potential case or a known case, the optimal time to get tested, and we presented on this before, is at earliest 4 days, ideally 5 days, right? Anything sooner than that risks having a false negative. If you test on the day of exposure, you're about 100% chance and likely to have a false negative. Obviously, that number decreases slightly on day 2, optimizes around day 5, and then increases likelihood of having a true positive thereafter.
And we have one final question, and then we can wrap up. Have you worked with any employers who are critical infrastructure that have followed the guidelines letting employees who are exposed continue to work if they are symptom-free? If yes, has this led to an increase in workplace spread?
The answer is yes. We have worked with employers in that scenario for critical infrastructure workers. And the answer is also, we don't know yet. Not enough time has elapsed, and we don't have the data collected to fully understand what the impact is or has been in terms of rates of transmission. Obviously, we haven't seen any big red flags immediately thereafter, right? But we do need to look more retrospectively at this data as time goes forward.
Okay, we got through all the questions today. Awesome. I want to wish everyone a happy Labor Day weekend. I hope you get some rest and relaxation. And I want to say thank you to all the workers out there who are going to out in the public every day to keep us safe and healthy. So we especially thank them on this Labor Day. And thank you, Dr. Harris, again for your time and your expertise. Take care, everybody.
Thank you so much, everyone. Take care, be safe, and God bless.